Hello and welcome friends. We are going to have the continuation lecture of the head injury, which will be having now we will be having the injuries or the hemorrhages in the brain, which are due to some venous injuries, due to arterial injury, due to rupture of the aneurysm, or due to some trauma which is happening into the brain and can lead to hemorrhages and other lesions. Cerebral hemorrhages can be divided into epidural hemorrhage, which is just outside the dura, subdural, below the dura, arachnoid, subarachnoid hemorrhage within the subarachnoid space, or intracerebral hemorrhages. These are the different hemorrhages that can be classified according to the membrane layer or the membrane spaces in which they happen. We can further see in the diagrams that if extradural hemorrhage means this is the dura matter which is the covering the brain and it is attached to the bone. If an injury happens to here, like that is the fracture line here, then the chances are there is a accumulation of the blood and detachment of dura from the bone periosteum and the blood collects here. So hemorrhage is here, dura is pushed inside and it is outside the dura. If we see the diagram here, then we can see that it is the periosteum, this is the ostium, then we have periosteum here, then the dura mater is here, the subarachnoid space is here, pia mater also covering the brain, and the blood has collected into the space between the bone and the dura mater. Another diagram which will make the things clear: scalp, skull, dura mater, arachnoid mater, subarachnoid space, pia mater which is covering the brain, and it is the brain. It is the normal anatomy. If epidural hematoma, then dura is separated and pushed inside. Then we have accumulation of the blood between the bone and the dura mater, and subdural, dura is present there and in contact with the brain, and bleeding happens between the layers of the dura. There are different causes of the hemorrhages in subdural or epidural hemorrhages. In epidural hemorrhages, chances of middle meningeal artery rupture and can lead to accumulation of the blood and pushing of the dura mater, whereas in case of extradural subdural hematoma, chances are there are interbridging veins that rupture and the dura mater is in contact, rest part is pushed within the cranial cavity. We can see that it is a subdural hematoma and it is epidural hematoma. Epidural hematoma, bleeding between dura and skull, invariably traumatic in nature, associated with skull except in infants, skull fracture except in infant. In infant it can happen without the fracture, may be acute or subacute. Classical clinical course: loss of consciousness followed by lucid interval and then deep coma due to raised intracranial pressure. That's why we advise people to wait in the emergency for 24 hours so that all this period can be monitored and patient may be discharged in full recovery. Loss of consciousness followed by lucid interval means there is no symptom. Then person lands up in deep coma due to raised intracranial pressure due to reactionary fluid accumulation in the brain. Undergo rapid resolution without anatomic sequelae. If we treat the patient, the person can go in rapid resolution with no anatomical damage. Acute, due to rupture of the middle meningeal artery, patient loses consciousness. Unless the clot is surgically removed, patient rapidly dies. We have to remove the clot. The usual cause of death is respiratory failure due to brain stem compression. If there is a accumulation of the blood, it leads to the pressure of the brain structure, and since the respiratory center is located in the medulla, it compresses the medulla, and there are chances of that respiratory failure can happen. Subacute, when there is a slow release of the blood, where fracture tears the dural sinuses, middle meningeal vein or diploic vein. Symptoms are slower in onset. So if it is acute, very aggressive features will be there, and in subacute, where mild aggressive features can be observed. Medical legal important is prognosis is good with proper treatment. Patient may be discharged during lucid interval, and we doctors should be very much aware about the lucid interval in case of extradural hematomas, because chances are that the patient may go into unconsciousness after being discharged. The condition may resemble drunkenness, may be confused with heat artifact at autopsy. Heat artifact and the at autopsy, heat artifacts can be said that heat hematoma means that when there is extreme heat is applied to the skull, some of the blood or the artifacts which are collected in the skull bones seep into the extradural space and get hardened there, and we can confuse in autopsy that it is an extradural hematoma or a heat artifact, depending upon the we have to analyze, and there is a proper technique for that. Subdural hemorrhages, when the dura is intact and the blood is accumulated in the dural spaces, vascular injury where lead rapidly decelerate because of the impact to the firm and unyielding surface common in fall and assault. Means there is a rapid deceleration. Bleeding between under surface of the dura and outer surface of the arachnoid mater, I have already discussed that, commonly due to rupture of bridging veins, but may be due to tearing of cortical arteries, injury to the dural sinuses, secondary to disease process, example neoplasm, ruptured cerebral aneurysm, and not necessarily associated with skull fracture or the brain injury. Extradural hematoma was associated with brain or skull fracture, whereas subdural hematoma may not be associated with fracture of the skull. Classified as acute within 24 hours, subacute 24 hours to 7 days, and chronic. There are chances that person may develop subdural hematoma but with no features. In chronic, in subacute, person may have damage and can present within 24 to 72 hours, 7 days, 24 to 7 days with some symptoms, and in acute within 24 hours with symptoms into the emergency department. The causes can be torn blood vessels, subdural hematoma, compressed brain tissues, dura matters, it compresses everything, and this is the arachnoid layer. It is between the dura mater and the arachnoid layer, and it can compress the structures here, and it is generally due to the interbridging veins. Acute subdural hematoma is due to rupture of large bridging veins or carotid artery, cortical arteries. Onset of symptom is usually rapid and may become life-threatening within about 50 ml of blood. 50 ml of blood in subdural hematoma can lead to death also. High mortality due to associated with brain damage. If brain damage is there, then chances of mortality is very high. Subacute subdural hematoma is due to bleeding from smaller bridging veins, and these are less life-threatening. Chronic subdural hematoma is a result of torn or perforating dural veins, especially in elderly, which have hypertensive and or chronic rupture of the brain vessels. Hematoma is often secondary to silent trauma, or there may be any neurological deficit, except slight confusion. There may not be any neurological deficit. Person develops hematoma without any features and goes on, and it resolves and forms a membrane. We will be seeing forgetfulnesses and memorial behavior disorders. Chronic subdural hematoma consists of blood encased by outer membrane. If a chronic hematoma happens, then it gets resolved and a certain haline membranes are developed around it, and which can be dated depending upon the appearance of the layers of the membrane. Blood encased chronic subdural hematoma consists of blood encased by outer membrane underlying the dura and the inner membrane that separates the blood from the arachnoid and known as blood cyst. We can see it is here. It can develop into a encased clotting within the membrane that can be said that it is a blood cyst. Medical legal important changes in the dura, capillary dilatation 24 hours, proliferation of fibroblasts. This is all the development of the membrane around the hematoma. So, proliferation of fibroblasts under the surface of the dura 2 to 3 days, thin layer of fibrin under the surface of dura 4 to 5 days, red cell decomposition 5 to 10 days, true inner membrane formation 2 to 4 weeks, mature connective tissue with hemosiderin, hematoidin, laden macrophages 1 to 3 months. If we find in autopsy there is a chronic subdural hematoma, we can date it up to 1 month, 2 months, 6 months, how much number of layers are there around it. Extradural hematoma, subdural hematoma, this is the tabular form distinction. Extradural biconvex, temporal or temporoparietal region, middle meningeal artery may be the causating agent. 5% of all the head injuries, lucid interval is there, outcome related to the status of prior to the surgery. Subdural hematoma, diffuse and concave, entire surface of the brain can involve tearing of the bridging veins, 13% of the severe head injuries, underlying brain damage more severe, prognosis is worse than the extradural. Subarachnoid hemorrhages within the arachnoid space, causes can be berry aneurysm, aortic arteriosclerotic disorders, or the person with high blood pressure, leaking intracerebral hemorrhages, leukemia, angioma. Collection of blood is usually at the base of the brain. Arachnoid space, if it is arachnoid space, then it all matters, all the blood collects and goes at the base of the brain. Traumatic causes, cerebral contusion or laceration, asphyxia or strangulation, prolonged hyperextension of the neck like in bronchoscopy, blow to the face or neck due to laceration or vital arteries, vertebral or carotid or basilar arteries, there can be damage to the these arteries in the blow. Intracerebral hemorrhages means it is the hemorrhage which has happened within the brain, not involving much of the membranes. Can be post-traumatic or spontaneous, mainly due to cerebral vessels when close to surface due to laceration. Deep-seated hemorrhages in the cerebellum and brain stem may occur in association with other brain injuries. So, when there is a contusion or laceration injuries that go deep into the brain, that can cause intracranial hemorrhages. Factors to be considered are age of the victim, site and extent of hemorrhage, associated vascular diseases, cardiac hypertrophy, kidney diseases. These all can contribute in either way to increase the bleeding or the chances of hemorrhage in the brain. Intracerebral hemorrhages can be spontaneous or can be due to the injury. If it is spontaneous, it can be caused by hypertension, aneurysm or aortic diseases, atherosclerosis we can say. Age, past middle ages, and onset is sudden. Position, any. If it is spontaneous, not traumatic, then mechanism, rupture due to disease, location, ganglionic regions, concussion generally absent, coma present or maybe sometime patient will end up in coma. In post-traumatic, head injury is there, young ages because of the young active people, onset variable, position, head in motion, head should be slightly in motion, mechanism, coup and counter coup injuries can be there, location generally white matters, concussion generally present, coma may be present or it can be variable. Medical legal aspect, in case of a comatose patient, we have the one aspect that is consent. Patient expresses even while incompetent preferences. So we have, this is very tricky area, we should having proper consent. Religious belief of the person should be kept in mind. Impact of the head injured person's family, impact on the head injured person and its family, we should be calculating that also. Probability of side effect from the proposed medical treatment, which we generally in case of head injuries we generally rush to the treatment because of the urgency of the treatment required. So we should be explaining a lot before going to a treatment, and we should explain the prognosis of not having treatment and the prognosis of having the treatment along with all the other possible outcomes. Medical legal issue to the remember, in case of person is going to coma or going into coma or subconscious or the stages, chances are there, then chances of death is there, then dying declaration should be taken. Concussion, transit and concentration should be kept in mind. Lucid intervals should be kept in mind. And focal lesions like clinical neurological deficiency should be kept in mind. Intervention, medical or surgical, which can be given, or recovery, total or complete or partial. No recovery, it can be prolonged coma, incomplete recovery, disability, varying degrees, partial, temporary, partial, permanent. So we have to explain, and we have to also explain the morbidity, how much the person can gain. It is generally a basically it is of a neurosurgical part, but we are having here also complete bedridden can be, loss of life, loss of earning, inability to do routine work. Disability assessment, this is generally come to our or orthopedics department, ortho or forensic. Compensation is generally in the forensic medicine. Accident claims, this is part of investigation. Industrial claims, it is also parts of claim. Tort cases, also sub judice. Criminal cases, simple injury, grievous injury, dangerous injury, this is also our forensic medicine domain. We should be very much clear about the criminal cases that can precede or can come in the future. Thanks a lot for the being patient with me for the head injury. In the coming lectures, we will be having something discussion on the other regional aspect of the body. So thanks a lot for being patient. Thank you very much.